My topic is about Leber's optic neuropathy, the evolving genetic and therapeutic landscape. These are my financial disclosures. I don't own any stocks or shares in the various companies mentioned in this presentation. Leber's optic neuropathy is named after Theodor Leber, who was a German ophthalmologist who worked at Heidelberg University Hospital. He's very much viewed as the father of modern European ophthalmology, and quite a few other conditions are named after him besides Leber's optic neuropathy. We have to go back to 1871 when Theodor Leber first described the key clinical features of Leber's optic neuropathy, namely that it tends to affect young men, it has a poor visual prognosis, and it's transmitted down the maternal line. We have to wait until 1988 when the seminal paper was published by Doug Wallace and Ivan Ikoski-Leinen in Science, describing for the first time that a point mutation in the mitochondrial genome, in this case 11778, can cause human disease in large pedigrees with a clear-cut LHON phenotype. LHON is the most common cause of mitochondrial blindness, and the minimum prevalence, at least in the UK, is 1 in 30,000. It is a primary mitochondrial DNA disorder, and we know that 3-point mutations in the mitochondrial genome account for about 90% of cases, and these are known by their numbers, 3460, 11778, and 1444, and by far 11778 is the most common mutation worldwide. In the white Caucasian population, the 11778 mutation accounts for around 60 to 70% of cases, but in Asia, this is much higher, even going as high as 90%. Who gets affected with this condition? So this is a disease that tends to affect young men between the ages of 15 and 35. If you carry a LHON variant, you're more likely to lose vision before the age of 50. So 90% of LHON carriers who are going to lose vision will lose vision before they turn 50. It's a pretty dramatic presentation. These patients present with painless central visual loss. There's very severe reduction in visual acuity. And unfortunately, in about 25% of cases, both eyes are affected at the same time. If only one eye is affected, the other eye goes down the same way about 3 to 6 months later. So this is invariably a bilateral optic neuropathy. The visual prognosis is not very good. You can get spontaneous visual recovery. It is more likely within the first year and more likely if you carry the 14484 mutation. This was a systematic meta-analysis conducted with my good friends and colleagues, Nancy Newman and Valerio Carelli. And this was a meta-analysis of nearly 700 patients carrying the most common 11778 mutation. And if you look at people who are 15 years or older, just over 10% had some degree of visual recovery. And the degree of visual recovery is usually limited and incomplete, meaning that most of these patients will remain within the legal criteria for blind registration. It has a huge impact on quality of life, and we conducted this study many years ago, which shows a significant socioeconomic impact with very high rates of anxiety and depression. So what are the pathogenic mechanisms? All the 3 common primary LHON mutations affect complex 1 subunits. And because of this, you get an increase in the levels of reactive oxygen species and impaired ATP production, which leads to retinal ganglion cell dysfunction and ultimately cell loss. If you have a very strong clinical suspicion of LHON and the patient is negative for the 3 common mutation, the next step is to consider whole mitochondrial genome sequencing. I won't go over this, but there are a number of reviews out there which give you a long list of these rarer pathogenic mitochondrial DNA mutation, which can cause LHON in a few families worldwide. The genetic landscape has been evolving very quickly over the past 5 years. This very interesting paper from the group of Valerio Carelli in Bologna shows quite intriguingly that sometimes some mitochondrial DNA variants are not pathogenic on their own, but in combination, they can impact mitochondrial function, causing Leber's optic neuropathy in a few families, but this is relatively rare. What is really fascinating is that we're starting to understand how there is a very close synergistic interaction between the mitochondrial genome and the nuclear genome, which produces most of the proteins needed for normal mitochondrial function. And we wrote a commentary last year with Tony Moore, and clearly, if you see a patient with a clear-cut diagnosis of Leber's optic neuropathy, whole mitochondrial genome sequencing is negative, then you should really think about doing whole exome or whole genome sequencing if that has not been done already in the first place. The reason for this is that we now have very interesting data showing that nuclear gene mutations can cause a LHON or a LHON-like phenotype. The first paper was from the group of Jean-Michel Rosé in Paris, who identified recessive mutations in NDUFS2 as a cause of non-syndromic LHON-like optic neuropathy. So this gene is a nuclear-encoded subunit of complex 1, and mutations will disrupt complex 1 activity. The other gene that was reported was last year by the group of Tariq Bhatti and John Chen from the Mayo Clinic, where they identified recessive NDUFAF5 mutations. Again, this is a gene which encodes for a subunit of complex 1, and again, you have the recurring theme of an impact on complex 1 activity. And then after that comes the other gene, which is DNAJC30, which again has an impact on mitochondrial respiratory chain complex activity. It causes a very interesting phenotype, which tends to be much more prevalent in people of Slavic origin. So you get in Eastern Europe and in Russia. And for all matters and purposes, the phenotype is the same as LHON caused by primary mitochondrial DNA mutations. So the bottom line really is that you can get rarely nuclear gene mutations that cause Leber's optic neuropathy. We're going to talk a lot about treatment in this symposium. I'm just going to mention a few things that we need to keep in mind. So various treatment modalities have been considered, including neuroprotective drugs. And we can't really talk about treatment for LHON without talking about idebenone, which is a synthetic ubiquinone analog. What idebenone does, it pushes the flow of electrons along the inner membrane, which increases ATP production and decreases the level of reactive oxygen species. Back in more than 10 years ago, we conducted this RHODOS trial, which was the first properly conducted randomized placebo-controlled trial of idebenone in Leber's optic neuropathy, where 85 patients were randomized to idebenone or to placebo, but this was quite a short study of only 6 months. What we saw was there was a much higher response rate in the idebenone-treated group, around 30%, compared with placebo, which was 10%. But because this study was only 6 months, we did not see the full benefit of idebenone treatment. After that, there was an expanded access program in Europe and North America, which included 111 patients treated with idebenone at a dose of 300 milligrams 3 times a day. So this is the key results from that study. If we look at the rate of clinically relevant recovery, you can see here that at 12 months, this was around 30%. But if you treated the patients for longer, for up to 2 years, the rate of clinically relevant recovery increased to about 45%. So there is benefit in continuing treatment for longer than 1 year, for at least 2 years. If you look at this figure here, the mean time when you get the recovery is about 10 months. But the difficulty with the expanded access program is that there was no comparative normal natural history data to compare with. Which brings us to the LHEROS study, which was a larger study of nearly 200 patients with Leber's optic neuropathy and a confirmed mutation. I'm just going to give you the headline results here. We analyzed 181 patients as part of the intention to treat group, and treatment with idebenone was given for 24 months. We also had a natural history cohort of nearly 400 patients for comparative purposes. So let's look at the outcome measures here. So we look at the rate of clinically relevant recovery. We also look at whether or not vision was maintained at a logMAR of 1.0, meaning that there is clinically relevant stabilization. If you combine the clinically relevant stabilization group with the clinically relevant recovery group, you get the overarching group of patients with a clinically relevant benefit. So if we look at patients with disease duration of up to 1 year in the subacute and dynamic group, we can see here that there is a significant difference between the idebenone treated group, which is in orange, and the control group, which is in gray. And this was highly significant. If you continue treatment for up to 24 months, again, you have a larger proportion of patients who responds to idebenone treatment, and this was highly significant. There's always been a bit of controversy as to whether or not you should be treating chronic patients of more than 1 year with idebenone, and this study answers this question. If we look at the rate of clinically relevant benefit between the idebenone group and the natural history cohort, there is a significant difference. At 24 months, we get more or less the same results. So the bottom line is idebenone can improve vision in chronic patients with duration of visual loss between 1 and 5 years. So this is just start, and the therapeutic landscape is getting very exciting with gene therapy and other advanced therapies coming around the corner. At least in Europe, idebenone Raxone is the only treatment which has been approved for use in patients with LHON. Lumevoq from Genzyme Biologics is currently being evaluated by the European Medicines Agency. But if we look at the pipeline, we've heard about the exciting pipeline from Neurophthalmologist, but there are other treatment modalities which are being considered by various companies worldwide. The other thing which I think is really important to consider is gene therapy takes time. And one way that we could potentially help more patients is to have a mutation-independent gene therapy using, for example, neurotrophic factors that can enhance neuronal survival, meaning that we can use this irrespective of the disease gene which is causing the loss of retinal ganglion cells. The other thing which I will mention very quickly is mitochondrial gene editing, which is a really fascinating area which could be transformative. And this is really the key question, why do we not simply correct the underlying pathogenic mitochondrial DNA variant? Well, this has been very difficult because obviously you cannot use classical CRISPR to edit the mitochondrial genome. But now there's been a number of studies being published, including from Michal Minchuk from Cambridge, showing that we can actually edit the mitochondrial genome. And therefore, this is no longer science fiction. So these are my final thoughts. The one thing to keep thinking about is that LHON can be caused by recessive mutations in nuclear gene that disrupt mitochondrial complex 1 activity. So very soon, I guess we will all be doing whole exome and whole genome sequencing if we're not doing it already. Idebenone is the only approved treatment for LHON, at least in Europe, showing benefit for both subacute dynamic and chronic disease. Gene therapy for LHON, for the 11.778 mutation in ND4, is leading the way in the field of mitochondrial disease, and mitochondrial gene editing as a therapeutic tool is now a reality. Thank you very much for your attention.